So next, we're going to be jumping into some clinical perspectives. So we have two more presentations in that regard. One is going to be coming from Zoe and Dr. Sid from Boston Children's Hospital, and then we'll also be having a report from Emma Palmer down in Sydney, Australia. So I will turn it over to Dr. Sid and Zoe.
All right. Awesome. Let me just pull up the slides. Okay, well, hello, everyone. It is such a pleasure to be a part of this conference and to have the opportunity to speak to the Kleefstra community. My name is Zoe Frazier. I'm a genetic counselor at Boston Children's Hospital. And today, Dr. Sid Chavasta, also known as Dr. Sid, and I will present updates on the Kleefstra Clinic at Boston Children's. So overall, we are a multidisciplinary clinic that provides evaluations and clinical care to children with Kleefstra syndrome. We aim to serve as a resource to the Kleefstra community, but it's also important to highlight that we learn so much from each family that comes to our clinic. Each family contributes to our wealth of knowledge, and we feel really privileged to have the opportunity to work with such an engaging community. So the main providers in our clinic are Dr. Sid and myself in the neurology department, and then Ann O'Donnell is also a geneticist who works in the genetics department. Our clinic is a part of a large hospital, Boston Children's, and we work to harness the resources and collaborate with other providers at Boston Children's. And so we have partnerships with other specialties such as psychiatry, sleep medicine, gastroenterology, and ophthalmology.
Great, thank you so much, Zoe. For those who don't know me, my name is Sid Chavasta, and I'm one of the neurologists at Boston Children's, focused on neurogenetics and neurodevelopmental disabilities, and I help run our Kleefstra Clinic here. And it is, once again, it is such a tremendous honor to be able to talk to you and to learn from all of you, from everybody here. And I'm very delighted to hear all these wonderful talks today. I wanted to go through characteristics of the patients we've seen so far in our clinic. I hope this information may be helpful, may be useful to give a general sense of some of the challenges and needs of the community at large. We looked at data over the past year and a half. Most, though not all, of the patients are captured here in the slides that I'm going to show you. I'll show you data on 44 participants. Over 2/3 of these patients are girls, while about half, or 1/3 are male. I've also plotted age ranges of the participants, of the patients. The greatest age range comes from infancy to early childhood, followed by age 6 to 10, age 11 to 5. This number declines with older age groups. It's not surprising that I think more younger kids tend to come versus older individuals. Interestingly, there were several individuals we saw ages 21 to 25, and even some individuals 26 years and older. And next slide. I also wanted to give a sense of where the families are coming from to see us. The gray represents states where we have not seen patients, but shades of blue represent number of patients from different states. Light blue is 1 patient from that state, slightly darker is 2 patients, and so on, all the way up to very dark blue being 7 patients. We saw the most patients from the state of Massachusetts, which is not terribly surprising given that's where we are located. We did see a number of patients from some Midwest states like Illinois. Next slide. Now I wanted to talk as well about some of the clinical characteristics of the patients we have seen, starting with genetics. 37% of the patients we've seen have a chromosomal deletion that includes EHMT1. The remaining have a non-chromosomal or intragenic defect affecting EHMT1. I've listed the specific types of intragenic misspellings. So 32% have a frame shift misspelling, and that's basically where there's an insertion or deletion of several letters that lead to a bunch of erroneous amino acids that are built into the protein, followed by a premature stop signal. 2% have a missense variant, that is a substitution of one amino acid for another. 11% have a nonsense variant, which is when one amino acid is substituted by a premature stop signal. 7% have had a partial gene deletion, that is a portion of the HMT1 gene is deleted. And 11% have a splice site variant, which affects how the coding and non-coding portions of the gene are arranged. Next slide. So what about the cognitive characteristics of the families we've seen? The vast majority have intellectual disability, which is defined as having an IQ more than 2 standard deviations below the mean, or global developmental delay, which is a label we sometimes use in younger kids under the age of 5, sometimes as a precursor to the intellectual disability label. Notably, there were a few families we saw whose children had IQs in the non-intellectual disability range, which is quite interesting, I think. In other words, ID is certainly commonplace in Kleefstra syndrome, but it's not universal. It's not 100%. Next slide. What about behavioral challenges? By far, the most common behavioral diagnosis we saw was autism or autistic features, affecting 40% of the patients we've seen. This was followed by attention deficit hyperactivity disorder. Other challenging behaviors include aggression, binge eating, and OCD, obsessive compulsive disorder, just to name a couple of examples. Next slide, yeah. So we looked at mood characteristics as well. Among mood characteristics, anxiety was relatively common, affecting close to 20%. Depression also was relatively high. It occurred in about 10%. There were a few individuals with catatonia as well as psychosis and hallucinations. And although I didn't mention this, actually I'll call this out specifically, in terms of regression, I think about 3 out of the 44 families we saw reported a history of regression, which is a low number. It's actually surprising to see that, but there could be, it just could reflect the fact that we're not seeing kids over the life, or we haven't, at least not yet, we're seeing families for the first time initially, and maybe there was regression that happened earlier on, or and that wasn't, well captured. So just a caveat about that number. Next slide. Actually, Zoe, could you go back to the previous slide? Yeah. So the topic of seizures comes up a lot, has come up a lot in our discussion with families. Interestingly, not that many patients that we've seen have presented with the diagnosis of seizures or epilepsy. 7% had a diagnosis of epilepsy. And remember, epilepsy is defined as having 2 or more unprovoked seizures in one's lifetime, or having one unprovoked seizure with the high likelihood of having a future unprovoked seizure. There was an equal percentage with a history of abnormal EEG without clinical seizures. There's also a small number of individuals who had febrile seizures. Next slide. Okay, great. I've listed some of the other neurological challenges that families have reported, experienced. Sleep challenges by far are quite common. So this includes obstructive sleep apnea, periodic limb movements of sleep, and just reports of generally disrupted sleep. So altogether, these sleep challenges are seen in maybe about a quarter of patients, which may be an underestimate, I think. CVI or cortical visual impairment affected 40% of the patients we saw. Dysphagia, which is trouble with swallowing, coordinating those movements, affected 16%. And microcephaly, which is defined as having a small head size, was seen in 18% of the patients we saw. Next slide. So finally, here is a list of the various types of systemic challenges that have been seen by our families that we've seen. The vast majority had GI challenges. They include constipation, reflux, and so forth. Many have had cardiac issues, including congenital heart defects. I won't go through each of these categories, but needless to say, there is a wide assortment of systemic challenges in addition to the neurodevelopmental and neurological and behavioral features that we see. Next slide. So this is, of course, a very high-level overview of the common set of challenges that patients who come to us have reported. Once again, I really want to emphasize how much it's a privilege, how delighted we are to learn from each and every one of the families. And we're so gracious and so thankful for everybody's time, effort, and being able to learn from each and every one of you. And it really inspires us to do our best to try to optimize clinical care. So once again, thank you to each and every one of you, to the families out there. Great, thanks.